Hello friends, welcome back to BGS Clinics. In this video, I'm going to explain how to analyze clinical data to arrive at a diagnosis, the most crucial step in clinical medicine. This topic is of paramount importance. Without making a clinical diagnosis, we will not be able to select the most appropriate investigation. We will not be able to interpret the reports of investigations critically, and we will not be able to treat the patients properly and confidently. So, the bottom line is you have to develop mastery in arriving at a clinical diagnosis. What exactly do you mean by diagnosis in the first place? Diagnosis is a label to particular changes in anatomy and physiology brought about by a disease. Try to understand. The causative factor of a disease leads to a series of changes in the structure and function of one or more system, organ, or tissue in the body. These changes manifest as symptoms, signs, and abnormal results of investigations. Inference from all these gives a total picture of various changes that have occurred in the body, and the label given to this picture is called diagnosis. So, it is the analysis of symptoms and signs that leads us to the diagnosis. To analyze the symptoms and signs means what exactly to do? Let us see that. Try to relate every symptom and sign to anatomy, physiology, and pathology. That means from every symptom and sign, try to determine the site of the disease, functional disability, that is, what has gone wrong with the physiology, which in turn may help to determine the site of the disease again, and the pathology. If a symptom or a sign can determine all the three, then arriving at a clinical diagnosis will become pretty easy. But that doesn't happen in practice in every case. Anatomical plus pathological diagnosis may be labeled basic diagnosis. And the so-called complete diagnosis includes the presence of comorbidity, if any. I have explained this in the video on principles of clinical case taking. Now let us see how to analyze the clinical data step by step to arrive at the diagnosis. First and foremost, decide if the condition is acute, chronic, or acute on chronic. Acute means duration of the problem is up to a week. Mode of onset usually sudden. Progress usually rapid, that is in hours to a couple of days, and the patient may look distressed. Chronic means the condition spans over more than 3 weeks. Mode of onset is usually, though not always necessarily, insidious. Progress is slow, occurring over weeks, months, or years. Do you know or remember what insidious onset means? Please see the video on history taking. Acute on chronic means basically a chronic disorder which at some point of time during the course presents as an acute case. Now, apart from these, there is one more category, subacute. It spans over a period of up to 3 weeks. The second step is to fix the anatomical diagnosis. That is, determine which anatomical region, body cavity, system, organ, structure, or tissue seems to have been affected. These are the clinical points which may help you to determine the site of the disease. The chief complaint and/or symptoms of dysfunction of an organ or tissue and/or localized tenderness if present. For example, if a patient presents with, say, pain in upper abdomen, nausea and vomiting, and tenderness in epigastrium, which organ you think might have been affected? It could be stomach, liver, or pancreas, or maybe gallbladder in some cases, isn't it? If a patient presents with, say, pain in right lower quadrant of abdomen, nausea and vomiting, and tenderness in right lower quadrant, which organ you think might have been affected? Most probably appendix, right? If a patient presents with dysphagia, which organ might have been most probably affected? Esophagus. Okay? In many cases, depending on how much advanced the disease is, the patients may have additional symptoms and signs as well. In that case, it may be relatively easier to come to a diagnosis. The real challenge, however, lies in the ability to diagnose the disease early when patient presents with only few symptoms and signs. Though not impossible, it may be difficult, especially if symptoms are not specific. I have discussed about specific and non-specific symptoms in the video on the principles of clinical case taking. So, in short, any one or more of these clinical points at the minimum enable us to fix the anatomical aspect of the diagnosis. The chief complaint, symptoms of dysfunction of an organ or tissue, and localized tenderness, if any. The third step is to fix the pathological aspect of the diagnosis. What do you mean by pathology? Pathology basically means the study of disease, and that involves the process and picture of a disease. Process means the etiology and the subsequent dynamic changes which alter and convert a normal structure to an abnormal one. That is what is called etiopathogenesis. And the final picture of altered anatomy, studied traditionally by the naked eye examination, that is, gross examination of a specimen, and light microscopic examination, is called pathologic anatomy. Pathology may be broadly classified into general and specific. The specific pathologies occur in specific region, system, structure, or organ in the body. This is the list of pathologies which may be considered under general category. The absence or excess of a tissue or organ, malformation, herniation, ptosis or prolapse, collection of, say, a clear fluid, blood, bile, pus, etc., congestion, degeneration, deposition, infiltration, inflammation, end result of inflammation, namely necrosis, suppuration, ulceration, and fibrosis in that sequence, tumor, hyperplasia, and gangrene. Malformation may result from structural defect, formation of diverticulum, dilatation or narrowing which affect essentially the tubular organs, hamartoma or hypertrophy. Please remember, however, that the general and specific categories are not watertight compartments. Some of the pathologies under the general category may, in fact, be specific in some organs or tissues. For example, in case of a swelling in the breast, there is a dictum: a swelling in the breast must be considered malignant unless proven otherwise, except during the teenage. So, a malignant tumor becomes a specific pathology in the breast in addition to nodularity, fibroadenoma, and Phyllodes tumor. Okay? Now let us see how to fix the pathology in a given case. The first thing is, from the patient's clinical database, select one or two symptoms and or signs which are fundamental, primary, prominent, definite, and easily verifiable. Okay? I repeat, select one or two symptoms and or signs which are fundamental, primary, prominent, definite, and easily verifiable. And then consider those pathologies from the list which can give rise to those symptoms and signs. That's it. In other words, it's as simple as solving a match the following question. Let me explain with a couple of examples. The fundamental symptom is, say, a reducible swelling in the groin, and on examination, the swelling is found to exhibit an expansile impulse on coughing. Which pathology will you consider from the list here in front of you? Herniation, right? Now another example. An older female patient presenting with something coming out per vagina. Which pathology will you consider now? Most probably prolapse of the uterus, isn't it? While doing so in practice, always think of common diseases first. Think of a rare possibility and you will be rarely right. Think about rare disease only if all common possibilities are ruled out. Sometimes a pathognomonic symptom or sign may be present which then leads to the diagnosis effortlessly. Pathognomonic symptom or sign is one which is characteristic enough to clinch the diagnosis. When a pathognomonic symptom or sign is present, then all other symptoms and signs sort of lose their value, and yet you will be able to reach the diagnosis. For example, a swelling in the groin which reduces with gurgling. And the second thing to determine in pathology is the etiology of the problem. Etiology means the cause of the disease, and it comprises of pathogenic agent and predisposing factors. These all are the pathogenic agents: injury, infection, infestation, drug means medicine, poison, allergen, foreign body, functional, and psychogenic. Sometimes, however, the pathogenic agent may remain unidentified. Injury may be mechanical, thermal, radiation, or chemical. Infection may be bacterial, viral, or fungal. Poison may be of animal origin or plant origin, and it includes carcinogen as well. Allergen may be external, but sometimes patient's own body protein behaves as a foreign body protein and leads to autoimmune disorders. There is a difference between functional and psychogenic. Okay, they are not the same as many people often think. I will discuss that in the video on chronic pain in abdomen. And these are the predisposing factors: age, gender, race, religion, residence, diet, occupation, heredity, pregnancy, mode of contraception, hypersensitivity, immunosuppression, activity/inactivity, and lifestyle, faulty posture, and deficiency or absence or excess of basic physical or physiological needs, namely oxygen, clean water, fresh food, heat, pressure, and protection. Information about most of them will be available when you obtain history from the patient. Now do you understand why a clinical case must be taken in details without taking shortcuts? Every, even the apparently smallest clinical point may give you a clue to the diagnosis. To explain the etiology, let us take an example of pulmonary tuberculosis. What is the cause of pulmonary tuberculosis? Mycobacterium tuberculosis. Well, that is a bacterium and that is the pathogenic agent which will actually cause the disease. Fine, but When does a person actually get diseased from it? Whenever the person is predisposed to. And what are the predisposing factors? One or more of these. Staying in an overcrowded locality or traveling regularly in an overcrowded transport because of which the person is exposed to a high load of infection. Undernutrition, which reduces immunity. Healthcare providers like us, the doctors, nurses, ward boys, etc., who are again exposed to infection more than others. Heredity is also known to play a role. Immunosuppression is a very important predisposing factor. That is why you will see a high incidence of tuberculosis in patients suffering from AIDS. Now, a piece of advice from me at this juncture. Mug up these two lists by heart: pathologies and the pathogenic agents. Your ability to arrive at a clinical diagnosis will improve many folds if these points are available to you at the tip of your fingers. This will help you a long way in your life as a clinician. I am telling you from my personal experience. It works well. And finally, look for any comorbidity if present. What are the practical implications of comorbidity? A congenital anomaly or a permanent disability may influence the selection of appropriate treatment modality. Any chronic systemic disease, if present, should be well controlled before any intended surgical treatment to avoid perioperative complications. If a patient happens to suffer from any short duration illness such as common cold, cough, flu, etc., before a planned surgical treatment, then surgery should be postponed for a few days to weeks until the patient recovers completely. So these were the steps to reach a complete diagnosis clinically. Let us recapitulate them briefly. Step 1. Decide, is the condition acute, chronic or acute on chronic? Step 2. Fix the anatomical site of the disease. The minimum clinical points required to fix this are the chief complaint, physiological dysfunction, and localized tenderness if present. Step 3. Determine the pathological aspect of the diagnosis. For that, firstly, find the best match of the pathology for the symptoms and signs which are fundamental, prominent, primary, and easily verifiable. And secondly, determine the cause in terms of the pathogenic agent and predisposing factor. And finally, look for any comorbidity if present. With the help of these steps, make a hypothesis of your diagnosis and justify it with the help of the basic point, differentiating points, and supporting points. It is the differentiating points which put the stamp of diagnosis. Now I will give you a practical demonstration of how to justify the diagnosis. If you submit the diagnosis as uncomplicated oblique inguinal hernia, how will you justify it? Well, because basically an inguinal swelling or an inguinolabial or inguinoscrotal swelling that is superomedial to pubic tubercle, and the differentiating points are the swelling exhibits expansile impulse on coughing and it is reducible. If you submit your diagnosis of acute cholecystitis, how will you justify it? Basically, acute inflammatory abdomen involving the right upper quadrant. What are the criteria of acute inflammatory abdomen? Severe, steady pain of sudden onset, anorexia, nausea, and a few bouts of vomiting, fever, and guarding or rigidity in the area or quadrant of abdomen in which lies the inflammatory pathology. And these are the differentiating points in favor of acute cholecystitis. Pain radiating to right infrascapular region, tenderness particularly at Murphy's point, and positive Murphy's sign. If the attack is a recurrent one, then it supports the diagnosis of acute cholecystitis. Belching, dyspepsia, and tender palpable mass, which may be present in about 25% cases, are additional supporting points. Dyspepsia is a scientific term. Patients describe it as indigestion. Look, acute cholangitis also leads to the basic findings suggesting acute inflammatory abdomen. Which are the clinical findings which differentiate it from acute cholecystitis? Intermittent high-grade fever with rigors, jaundice, and tender hepatomegaly. A possible known underlying cause such as existing gallstone disease or instrumentation of the biliary tract in the recent past, etc., would support the diagnosis of acute cholangitis. So that's it about how to arrive at a clinical diagnosis in a surgical case. Hope you enjoyed the clinic. I'm sure with the help of this roadmap or format, you will be able to make successful and confident attempts at arriving at a clinical diagnosis. Never get tempted to peep into the patient's file first before making your own clinical judgment. Don't allow your mind to get biased. Wish you all the best. See you again in the next video with another important topic: how to investigate a case after having arrived at a clinical diagnosis.